Welcome to the Medical Collective, your go-to podcast where medicine meets real life. I'm Dr. Keisha Davis, a pathologist, personal trainer, and your host. I will be joined by a vibrant team of doctors who are not just healthcare professionals, but artists, fitness enthusiasts, and advocates for change. Each episode, we dive deep into the world of medicine, from untold stories of the healthcare industry to the latest in medical advancements. We're here to bring your insights, answer your burning questions, and explore the art and science of healing. So let's get started and step into the world of the Medical Collective. Hello. Welcome. We are on our, 15th episode. We just did our 14th, and I'm glad that you are in and listening into this. This episode's a little different. You have me, and I thank you all for being here. For those that are listening in, hello, Tina, and to all those that are going to be over on YouTube as well, hello. I hope you're doing well. Hi, YouTube. You can take your chat and share in the chat the conversation. I really do appreciate it if you do listen in or chat in, ask a question. That way you can get it answered in real time. But today is a beautiful Wednesday in the middle of May. And it is also important because we're going to talk about cancer diagnosis. And as many of you know, I hope that I am a physician that is board certified in diagnosis. So a pathologist is one who studies disease. And what I study is disease in tissue, disease in blood, and also tiny pieces of disease from cells is cytopathology. And everything that goes through the lab is part of the diagnostic regimen that a pathologist does. So we're going to talk about that, and especially because of one of the top hot topics of today. And that hot topic is, and hello to the people over on YouTube, please share and be part of the conversation if you can. The first thing I want to talk about was former President Biden's cancer diagnosis. Now, I did not know. And last time we spoke about this, right, we said that there was upon examination, and as many people know, former President Biden is over 75, but upon examination, a nodule was found, and we knew they were going to do a biopsy. Now, what has become a problem is upon that biopsy result, there has now been the doctors that come out from TikTok and social media that are saying, oh, he knew about this should have been diagnosed, how does it get missed? And for those of us that are actually in medicine, this is an everyday thing. And it's actually sad because imagine if someone who has all of that ability, who is a former president, who has access to healthcare, is still getting diagnosed with metastatic disease. Imagine for those that can't. And I see this all the time when I'm going to my locums out in rural parts of Texas. So unfortunately, that's what happens. For those that are in the chat, let's see. Go ahead and chime in. It's interesting. Sometimes the technical difficulties you have when you're trying to stream by yourself, but it's okay. Hello, Zoe. Hi, Biscotti. Hello. Welcome in. Okay, so we'll get back to that. So what the news has been and what we talked about last time, check in, by the way, that episode is out. Episode 14, The Art of Medicine, The Art in Medicine is out. Amazing episode with Dr. Leslie, Dr. Sharon, and Dr. Tusa. It was so good. We spoke about the nodule, okay? And right now, there has been a lot of uproar about stage 9, stage 5, all of these things. And I think a lot of it is because people don't understand interpreting cancer diagnosis, right? And 99.999, 100% of all specific cancer diagnoses, not saying we think you have cancer, but the actual initial cancer diagnosis happens through the laboratory by a pathologist. So we know what we're doing. We're making sure it's correct as far as the diagnosis. In this case, what happens is that we get social media doctors that come out and start to purport they understand and they know. And actually, none of us know, even as physicians, we're going on what was posted or what was reported by his team. We're not going by anything else. I don't know when his last PSA actually was, though it was purported it was in 2014. I don't know exactly what the report said because we're just going on what was reported. But I will say this, that a cancer diagnosis takes a lot of steps, okay? First, there has to be a reason or warranting for a cancer diagnosis, or it's found on screening, which is why breast, cervical, colon, and prostate, they all have screening guidelines. Now, screening can help. It's like a net. I don't fish, but I know some people, my husband claims that he used to fish, and some people fish by netting or crabbing, right? Sometimes you get stuff in the net that you don't want, okay? Those could be our false positives. Sometimes you don't get what you want in the net, and it's still out there. That's your false negative. It should be in the net. Sometimes you have to do another one, or take stuff and pick it out. So screening to me is that net. It's getting as much as it can first time. It may miss, which is why, if you listen to the episode on Art of Medicine, why it takes a physician to understand the full body to make the correct diagnosis and do the right plan. But it still can catch a lot of things if you follow the screening guidelines. Now, what are we finding out? More people are getting cancer earlier. And as you age, you also have an increased risk of getting cancer. So why is it that we are not screening people all the way up to 80 or 90? So there is a balance. If you even know with immunizations, even though they're being put into media in a negative light, there's always a risk to benefit ratio. There are some people that maybe for their benefit, they shouldn't have it. But you have to look at the risk to benefit ratio. And they believe that as you get older, it depends, that not necessarily doing the screening is advantageous. So it really depends on the person. But Dr. Leslie has said that for her and her patients, she speaks to them, and even though it's a guideline to stop doing PSA, which is your prostate-specific antigen, at 69, that she still may continue to do it. And you're also asking risk factors. Do you have other cancers? Do you have a family history? Do you have genetic traits that we're concerned about? So you're looking at all those things to decide if we still need to do PSA. So technically, according to the guidelines, maybe Biden was following the guidelines. And so after a certain age, they're not doing PSA. So how do you catch it, Dr. Keisha? That's where training examination comes in. The DRE, which is the digital rectal examination, not everybody's doing that. That's not something that you're going to be doing like the PSA. When I say doing that, I mean as part of the prostate cancer screening. It's the PSA is the gold standard screening. So upon examination, and that's what we talked about, was where they found a nodule. And then we talked about a nodule. A nodule can mean a lot of things. So I won't delve into the nodule because the episode before this, the Art in Medicine, we spoke about that, and it's out. You can listen to it on all platforms. So when you talk about the nodule, they biopsied the nodule. Now, if you had a PSA, which is a prostate-specific antigen, if that was elevated, that alerts them that we need to investigate further. However, it could be inflammatory conditions can elevate the prostate-specific antigen, and BPH can as well, which is benign prostatic hyperplasia. So what these amazing urologists do is they go in, use imaging, and they'll do imaging-guided biopsies. Now, with the breast, when there is a breast lesion, I usually get a couple of cores from, like, if there's one breast lesion from 3 o'clock, I get a couple cores. The prostate's not like that because prostate cancer tends to be multifocal. I'm going to take this. It's shaped like kind of like a walnut, though, okay? The prostate is very, in the middle is where the hole is, right? And around it is how they call the right half, the left half. And then on each half, they divide it into upper, mid, lower. And then they have transitional, mid, and lateral. So literally, what they do is take 1, 2, 3, from 12 to maybe 24 to 26 biopsies. And each one they put in a special container, a separate container, because they want to know which ones are positive and which ones aren't. Because you don't have to always treat prostate cancer with prostatectomy, taking it out. You can do other types of treatment. So they'll do all these biopsies and sometimes 2 cores per area. And we're getting all of those and we're looking at each one of them. So that is now the step where they're trying to figure out, okay, is the PSA elevated? Do you see inflammation? Yeah. Do you see pre-cancer? Maybe. Or do you see cancer? And sometimes that happens. Sometimes the cancer we see can literally be 1 millimeter. And I'm talking tiny. Sometimes it can be a 1 millimeter, or it could be 1 millimeter here, one there. So it can be multifocal in that sense. Now, something else that can or has happened, and I've seen this with the talking, is now all of a sudden, not only are people now social media or TikTok doctors, now they are also pathologists. The 9 number is a score. I did a little video explaining this because the 9 is a score, and I said grade, but it's actually the pattern. So if we take, and I will show a picture in the actual final video for YouTube, you will see a picture of the prostate cancer, what we see in the scores. So we look at the prostate. If it looks very normal, we never go below a 3. We call it a 3. That's the pattern. If it does not look like prostate at all, it's just like sheets of cells, that's now a pattern of 5. So we take the 2 most common, and there's stipulations as well. So we take most of the time, we take the 2 most common patterns, or if there's a very high grade, we always have to include that one. So if it's 5 and then we see some 3, that's 8. If it's 5 and then we see some 4, it's 5 plus 4 equals 9. So the Gleason score, this is a histological grade that a pathologist only does, is 9. So when they took that, can you imagine to put that in a report and now the journalists are running with it? I think that confuses people. And to be honest, they should have just said a high-grade cancer, because I don't even tell people that are laymen or say, it was a score 9. I just say it was low, intermediate, or high grade. Because now they've taken that number and all they know is stage, right? But it's a histological score. So it's a histological score. That score allows us to know it's a high grade. That's what the urologist or the oncologists are going to use to decide what to do next. Now, you've got the grade, and now you know what it looks like. Now what are you going to do? The next thing is you're going to go in and you're going to take the stage. The stage is how extensive is the cancer. Now, stages are determined depending on the tumor. For a breast, the stages are different than how you would stage a kidney cancer or a prostate cancer. So the stage for former President Biden was based on the fact that it had metastasized to the bone, which is not good, but actually is one of the most common things where prostate cancer goes to is bone and sometimes brain. So that automatically puts him in a stage 4. So he has high grade, Gleason score of 9, which let's just say not even deal with that because that's made the confusion. And now he has a stage of 4, not a stage of 9, not a stage of 10, not 25. It's a stage of 4. But all of this confusion has made it into social media. And to be honest, first of all, politicized something that should not be political. And second of all, invaded the privacy of somebody going through a serious diagnosis. At the end of the day, still a human being going through a serious diagnosis, which is said prostate cancer. Yes, prostate cancer can be missed. All of these things are true. So wanted to make sure we cleared that up with prostate. But I wanted to talk about cancer in general. And again, thank you for those that are chatting it up and hello and here and on the YouTube Medical Collective page. You could be anywhere, but you're here on a fine Wednesday night speaking with me and listening to me talk about cancer. You're always welcome to chime in through chatting. You're also welcome to continue to follow, be part of these conversations. We have a Facebook group as well called Empowered Health Network that is here to help people gather and also deal with things they may be new to them during this time or understanding why we're not hearing a lot. And actually, speaking of hearing a lot, before we go on, there was an update, which was recalls. So we used to hear a lot more about outbreaks and recalls from CDC, from FDA. Those connections have been halted or kind of slowed down to almost 5 miles per hour because we don't have those people in place anymore, unfortunately. We've talked about many times the cuts. We actually had a whole episode on cuts and freezes and what that means, but it continues to happen to where we're losing a lot of valuable people and therefore information. I would say don't be scared, but be informed. And me and other people on social media will always make sure, because we do always have a foot on the other side to know what's going on. But, do know that you may have to be a little bit more on the ear or alert when it comes to outbreaks or recalls. You can go to FDA or search for FDA recalls, and you can find out about which recalls are happening in your area. Or if you're going to a store and you have like the card with it, make sure you're using the card. It's really important, because that way you can know when there's like an outbreak or something like that. A few of them, I don't consume milk. I stopped it, and actually for me, it's been the best thing ever. But one of them is ice cream, and it was multiple. I had to stop calling the names, you guys. The flavors, like it was Rocky Road. It was so many different flavors of ice cream, and there's been a recall with that for very good reasons, to be honest. Another one I wanted to share about was cucumbers. So vegetables too, why it's important to make sure you're cleaning and washing your vegetables. Please, anything that has a skin. What happens is you think you're taking the skin off, right? First of all, some people do cut the cucumbers and still eat the outside. I do. But imagine if bacteria is on the outside and you use a knife, you have transferred the outside bacteria into the inside of the food. So the best thing to do is just wash it. Make sure you're washing it and cleaning it, because you're not cooking cucumbers. So the only thing you can do is make sure that you are cleaning them before you consume them. And we see that. We've seen outbreaks with salad mixes, the pre-salad mixes, all of that. Again, because we don't have the FDA testing, we don't have the responses and the access to the response. We got to make sure we're vigilant, because we may miss something. Let me make sure. Yeah, we may miss something that could be detrimental. So stay tuned to that. We will talk about next time. Dr. Tusa, for everybody, is an allergy immunologist, and she's big on immunizations and explaining what they mean. So please, if you can, check her out on social media on all platforms. In the meantime, I wanted to tell you that the COVID vaccine policy changes FDA has spoken about. We are on the side of definitely very concerned, but still stay vigilant. And again, if you can get your immunizations, get them. What this means for the future and access and insurance coverage is yet to be determined. However, FDA has limited COVID vaccine approval to people over 65 and plus, and those with high risk. So those are the ones that are getting it. They're basically saying children, you're leaving out newborns, that special period. I'm sure Dr. Artusa is going to have a lot to say about that, but stay vigilant with these changes that they're wanting to implement. And also putting warning labels on immunizations that we already know. For those that have been following the medical collective, we'd explain vaccines, especially C19, which the mRNA technology is also used for cancer treatment, but understanding that the risks that we have seen with myocarditis are low compared to the risk of myocarditis from C19 alone. We've spoken about that, but unfortunately, we now have a politicization of science, and they're misconstruing things. And now they're taking that to where they're putting this on labels on immunizations. So very concerning, should I say, very concerning. Another thing, I love Shakira, actually. I love Shakira. I love multicultural music. And unfortunately, I knew this was going to happen. I'm going to tell y'all, when I go places, I'm masking up, or I'm making sure that I have my armor on, which is my immunizations, my health, all of those things. The Shakira concert had a measles outbreak, and we already knew this was going to happen. We're over 1,100 cases of measles in the United States. And now it's at the Shakira concert in New Jersey. For those that went, I don't know who's in New Jersey. There was a rise of cases, and I think that there was exposure at this concert, so they're speaking about it. So stay tuned. They do contact tracing, if you were there. Stay vigilant as well. You can necessarily not have all the lesions out and still be infectious. And we know that. We know that one person with measles can infect 12 plus people. The R naught score, which is the rate of infectivity, is high, and that we've had up to a 20% hospitalization rate from measles. So please, please be careful, everybody. Hello, listeners. We want to remind you that you can catch The Medical Collective on all your favorite podcast platforms. That includes Apple, Spotify, and YouTube. Be sure to hit that subscribe button so that you never miss an episode. We're also on Gleason, and you can find us on all social media platforms as The Medical Collective. Do you have thoughts or questions? Please don't hesitate to reach out. We love hearing from you. Now let's get back to the conversation. And for those that are wondering where bird flu is, a lot of us would like to know because the testing that was required to test our food products and the animals has basically gone downhill. So do not think that this is what, and I will say this as a physician and as a pathologist who believes in testing, your assumptions are as good as the data and the testing you are doing. So because we're not hearing about it, please do not think it's not going anywhere. In the animal world, in the veterinarian world, they're very concerned. Even cats, household cats are affected. So the fact that we're not hearing about it, it didn't just stop. It's that the data is being hidden because we're not having the testing available and they're suppressing it on purpose. So it's very concerning. I've never, in my little 40 plus years, I've seen it to where we are suppressing science and data. That's trying to help us all, okay? And actually, one thing that can hit the economy more than anything is science and health. With your health of the people, of your public health, the public health is as important to the economy as anything else. If your foundation is not strong, if people are not healthy, you're going to be putting more into the economy and wasting money, not having people to work these jobs, and then having to fix the ill population. So there's that. I wanted to talk a little bit about cancer diagnosis because I've mentioned I am a pathologist. And this whole dilemma with former President Biden has really sparked that people don't understand. I think a lot of people do. When we say breast cancer, when we say prostate cancer, there is not one breast cancer. There are multiple types, and an organ has multiple types of tissue. So the ducts are part of it, the lobules are part of your breast, and then the tissue that surrounds it that allows the breast ducts to stay in place. The stroma is also another part of your breast tissue, and cancer can arise in any part of those. And then two people can have the same cancer, the same lung cancer, the same prostate cancer, and you've seen that they can behave differently because on the molecular and biochemical level, what's happening, which is why now we test even certain markers for tumors to see if there's certain treatment, if it's sensitive. For instance, in former President Biden's cancer, it is androgen sensitive. So androgen deprivation therapy or treatment that's going to suppress that because the tumor loves or grows off of the hormones of testosterone to see if they can stop it from growing. And it can help. It can be very helpful. So there are things that can help us, but understanding a cancer and that they're all different is so important. So someone just saying they have cancer, skin cancer, for instance, which former President Biden had, basal cell carcinoma and squamous cell carcinoma. This is morbid, but our friends used to always joke, especially in pathology, and we said, if we ever could have a cancer, I would want it to be squamous cell or basal cell, because they're the ones that you take them out, you do a simple excision, and you're done. You're not going to get it back, right? Melanoma is the one you don't want to have. So if someone tells you they have skin cancer, that could mean a range of things. And also knowing with melanoma, you could have a melanoma excised. And the first oncology patient I saw in in medical school, the cancer came back at 20. So 12 years old, they had a melanoma. It was excised with what we call clear margins, meaning it looked like nothing was left. And at 20, she came back with a cough and made it maybe 2 years after that. And then she passed away from it. So you never know with cancer. You never know. And I think that we should leave the diagnosis and interpretation to physicians. And then even physicians, we're going to surmise or give you a roundabout explanation, but we're never going to try to diagnose an individual we've never seen. We're never going to do that. So it's mind-blowing that other people are trying or attempting to do that. Yeah. Also, one last thing, there is no stage 5 cancer when we're talking about former President Biden. I think you guys understand now, and then the grade and stage are two different things. Some of the problems, and I'm noticing because now I've gone from a medical center to a private practice to now filling in places in rural Texas, is that rural hospitals, those that don't have insurance, those that are traveling or now are afraid to go to the doctor because their immigration status is questionable. Those are putting hindrances, and to be honest, that's one of the things that I see. What I'm seeing with former President Biden is one thing, but imagine, like I said, the people where there's disparities, racial disparities, social disparities. And so getting a referral or getting access to care is a problem. One of the cases I had seen that was very bad, I think the person had went and had a procedure, gastrectomy, then came back from another country back here and actually had a signet ring, which is a poorly differentiated carcinoma of the gastric everywhere, all over the intestines. It was infiltrating everywhere. And it really makes me think about people, always wanting to go make sure they take care of their health, but forgetting the screening part of it. And if you don't have a primary care or one that cares, that's how we get lost. And we end up with these poorly differentiated metastatic cancers. Do I think that also in the system, people can get into the hospital? Imagine you have an annual. This happened to me. I had my annual. I took off because I love this one doctor, and she has a whole bunch of stuff going on. And so she had to cancel my appointment 12 hours before the appointment. So imagine patients having an appointment and losing their appointment. So that can be a problem. Not having enough doctors or getting a biopsy and having to wait a long time for the results. I would say with pathologists, we're still doing pretty well as far as I see. I don't see a shortage of pathologists to where we're not getting biopsies out. A lot of when it seems like it's taking forever to get your results, that's because it's a difficult case or there's a backup or we're sending it off for further testing. And that's a whole nother thing. But it's still getting processed and taken care of. I think that the delayed diagnostics is something that has been backlogged since the pandemic. We know during the pandemic, and I know this for true, outpatient surgery centers, what they called routine or non-emergency surgery was not necessarily just routine. Having a scheduled mastectomy for breast cancer, those cases were being put on hold. And what happens is once you tell a patient we're going to have to reschedule, sometimes it's hard to get them back in. So we are seeing delayed diagnoses because of that and delayed treatment because of that. Also, when it comes to diagnosing cancer, I will say that it depends on how we're diagnosing it. This happens sometimes. So it's not just a tissue diagnosis. For instance, we've seen, for instance, there's a child, high fever, all of a sudden not feeling well, right? Sick, worried about sick. You go to the ER, they run labs there. Those labs are part of stat labs. So they're in a certain part of the lab that are run frequently. And you find out your white count is like 25,000 for everybody. That's very, very high. And then what happens is they're like, well, a pathologist has to look at it. That's called a peripheral smear review. So the case gets, your specimen or your blood gets flagged, and the flag goes to the pathologist. Right now, sometimes that can happen the next day, unfortunately, or it's usually urgent to where we get called in and we're looking at if it's blast, because what happens is that you had a high fever, there's something that's not normal on the blood, and we look at it and we see what are called blasts. Blasts are immature cells from the bone marrow that should not be in the blood and that are actually cancer. And the the urgency is to treat right away, because you don't want to have, if you have so many blasts in the blood, it can be devastation and you can pass away. So those diagnoses happen from a blood smear. Literally just from a blood smear, we're diagnosing cancer. Multiple myeloma, sometimes plasma cells that are supposed to be in the bone marrow come out into the blood and are plasma cell leukemia. Then also, if you had an atypical blood smear, then they'll do a bone marrow biopsy, and we will get that. And that's where a heme path, sometimes regular pathologist, but also hematopathologist, very specialized, will look at that and literally under the microscope count the number of blasts and do studies and all these stains to find out exactly what type of leukemia you have. And if they have to send it to molecular, find out what translocation for CML or all those things. So there's a whole lot of things that happen for those type of cancer diagnoses. Also, if we're getting a small biopsy, we're going to say we need more tissue. That happens sometimes. And there are these things of cancers or carcinoma of unknown origin. And this unfortunately happens sometimes where the primary tumor is not large and it just happens. So this makes sense in a prostate. The primary tumor cannot be large and it just went all over the body because it goes into your lymphatic and blood vessels and spreads everywhere. And then it shows up as this metastatic lesion. And then now we're trying to figure out where it is. So then we have to use molecular, we have to use all of our big artillery and specialists to figure out where did this cancer come from. And there have actually been some where we don't find out. That's literally happened. Those type of cases can take like a month to 2 months to figure out. In the meantime, of course, they're treating with what they can, but we don't really, until we know where it is, we sometimes don't know how to treat it. In that thing. And, sometimes it could be a small little lesion where they do imaging. And then on imaging, they see the lesion, they go in with an imaging guided biopsy. Sometimes it's so small, or for the lung, they do what is called a FNA because they don't want to cause a pneumothorax. So they take individual cells. And now as a cytopathologist, I'm trying to diagnose the cancer. They can also get a core biopsy of some tissue or pancreas, what have you, and diagnose it like that as well. So I hope that makes sense to everybody about the diagnosis, right? So you are going to go away when someone says stage 5, you're going to say, are you referring to the grade or are you referring to the stage? And then you're like, say this, the grade is a diagnosis that's incorporated in the pathology report, and we don't have the pathology report. To be honest, that's where it should have stopped. It should have just said it was a poorly differentiated carcinoma. If someone tells you, yeah, it was 9, you should say, oh, are you referring to the Gleason score? So now you know there's a Gleason score. It's based on the 2 main patterns of a prostate cancer. And we add those together to get the score. And then we put it into the 3 buckets that I talked about. And the stage is something that's made. And to be honest, the stage can be hard to diagnose, because what we do is, even when I get a tumor of the colon, I can't actually stage it because I didn't get tissue from other organs to be able to say. So basically you're saying, for now, it looks like it's localized to the colon, but you never know. The only way you really stage something is by biopsying it and proving it's gone to the omentum. It's gone to another organ. It's in the lymph nodes up here. That's helping with the staging. And so we also, yes, have to make sure we're looking for prostatectomies. We don't really get them, but sometimes I have gotten inguinal lymph nodes. So that upstages it because now it's in the lymph nodes that it shouldn't be in there. So someone is sharing, and for those that are listening, all of this information is for your informational purposes, educational purposes, but at the end of the day, make sure you have a physician and a healthcare team to help you or guide you through any diagnosis that you have. And AskPath actually is a resource that I had started to help people understand their lab diagnosis. So someone has an upcoming oncology appointment because they found atypical lobular hyperplasia on the side of the breast that they said it's technically not cancer. So ALH is a finding that we see, and for everybody, it's the breast tissue, and we call it atypical lobular hyperplasia. Some things that we see in the breast: proliferative, or we call fibrocystic change with hyperplasia. So you've got fibrocystic changes, but you have some busyness to it, ductal hyperplasia, which is okay. All of these things slightly increase your risk for breast cancer. That's what it is. ALH is a marker that's saying you have an increased risk for breast cancer. It's not cancer. It's not DCIS, which is ductal carcinoma in situ. It's not It's not even LCIS, which is lobular carcinoma in situ, which actually is a prognostic marker as well, because it's used more to see that, okay, you have an increased risk of breast cancer. But that is what the ALH is telling you. So you would be one of us, like me, for dense breast tissue put into a category where you're going to get screened more often. And again, I'm not sure in your case, but in certain cases, they'll tell you you're going to get screened more often. In my case, I get ultrasounds and mammograms interchanged every 6 months with MRIs. So, yes, and I'm still here. And actually, I'm glad to have that knowledge because now I know I want to get the screening. How many more people are living with breast cancer now? 1 out of 8 women are going to get breast cancer. So the question is not, are we going to get it or affect us? What are we going to do about it? Are we going to follow the guidelines? Are we going to get screened? And if we're at an increased risk, are we going to follow those guidelines and continue with the more stringent guidelines with screening? The questions you ask your doctor, what I suggest is always putting them down and continue to keep notes on them. Right? Asking how often should I come back? What should I be looking for? Which, of course, self-breast exams, Dr. Sharon. And actually, there's an episode for those who have been tuning in, episode with breast cancer with myself, Dr. Sharon, and breast radiologist. I highly, highly suggest that you listen to that episode for both men and women. Great episode, a lot of knowledge. And the breast radiologist explained the imaging, calcifications, all of that stuff. It was so good. So yes, I highly suggest you listen to them. Also, I wanted to explain something about breast tissue. We have a lot of things going on in our breast, and ALH and ductal fibrocystic change is one of them. They don't form masses. So those are not necessarily things that can be taken out. Also, I have very busy breast tissue. If you just start taking out a whole bunch of tissue that's not necessarily a concerning lesion, is that when it comes time to find a lesion, because they're going to be following you, you're going to have a lot of other stuff going in from surgery. Surgical changes can obscure and make it more difficult for looking at imaging. So what the standards are is to continue to follow, and as they see whether mammogram sees atypical calcifications or ultrasound and MRI are seeing abnormal lesions, is then to get them done. I've had 4 biopsies at a time before. Then just having lumpectomies done until you're sure that you need a lumpectomy. And your surgeon, your breast surgeon can help you answer those questions for you. Because maybe there's additional things in the report, what have you. Okay. Then someone is saying that they don't have cancer anywhere in the family. However, daughter's grandmother passed young. So young breast cancer. And I'll say this. What is one of the most common breast cancer genes we hear about? BRCA, right? BRCA1 and 2. Did you all know there was a PALB2 mutation? Constantly we're finding there's many other genes that are linked to breast cancer. So it's not just BRCA. So it's important, first of all, I think, to have a family tree, literally, whether it's in your phone or somewhere where you have all this listed, and hypertension, all that stuff too. Cholesterol, people with high cholesterol, diabetes is important because those help. Those are familial things. But when it comes to cancer, to put that they had breast cancer at this age. If you know the type they had, and if they had genetics testing, that's good to know. Another thing is when you get genetic testing, you're going to have to get it periodically. And it's good to talk to a genetic counselor about that because new tests are always coming out. So I'm actually due probably for genetic screening again because it's been past 5 years. And as new things come out, they recommend getting it again, right? It's not a one and done because now there's new ways of testing additional genes they need to look for. And so that's an important to take into account. And actually, I think I'm going to have, if you do not know Dina, DNA on Instagram, please follow her. She is a wealth of knowledge. She is a genetic counselor, and she has come on other platforms and talked to us about breast cancer and other genetic. For instance, we talked about Lynch syndrome in one of the conversations. So please, please, please check that out. I hope everybody has a fabulous evening. Just remember, please remember, that cancer diagnosis does not happen in a vacuum, and it does not happen on TikTok or social media. And you do not have access to someone's report. So the first thing I think we really should do, I'm stepping back from the pathologist, and I do this, is that if someone's telling me this is what their diagnosis is, unless I have the report, I'm going to step back and in perspective and say, first of all, is it any of my business? But if they're asking my opinion, I'm going to do it from a broad standpoint. What's happening now is people are not doing that. They're not minding their business, and they're really politicizing a health issue. And no matter who has cancer, we should not be cancer. Another thing I saw, and I will say, is do not cancer shame. If you know someone that has breast cancer, yes, we know that a large percentage of cancers can be preventable and we can control them. But there are factors beyond our control. And once somebody gets cancer, is not the time to ask them, what did they do to deserve this? Whether it's spiritual or religious, or whether it's their lifestyle. They have cancer, and now we need to deal with it. Yes. So I thank you guys all for coming on. It's actually also Mental Health Awareness Month. Dr. Atusa has a friend that's going to come on our next episode. So before we close this month, so hopefully I'll put that up for Mental Health Awareness Month. And doctors and healthcare professionals, we need mental support, health support as well. So we will be talking about that. And I hope all of you take care of your health as well, and stay tuned for the next episode. Thank you. Thank you for tuning in to the Medical Collective. We hope today's episode has left you with valuable insights and a new perspective on healthcare. Don't forget, follow us on social media for more updates and behind-the-scenes content. I'm Dr. Keisha Davis, and it's been a pleasure to share this time with you. Stay healthy, stay informed, and we'll see you in the next episode, where medicine continues to meet real life. Please note that the content provided in the Medical Collective podcast, including text, graphics, images, and other material, is for informational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed on this podcast are solely those of the individual authors and guests and do not represent those of the Medical Collective, its staff, and any affiliated entities. The appearance of content on the podcast does not imply an endorsement. Neither the host, Dr. Keisha Davis, the co-host, or any guest of the podcast bear responsibility for the accuracy of the content provided or the use of information received through the podcast. Reliance on any information provided by the Medical Collective podcast, its employees, writers, or guests is solely at your own risk.